I am Soohong Kim. Today I will lecture about factors contributing to the long-term success of dental implant and preventing complications. Part 1, factors of the long-term success will be introduced. The content is composed of clinical success criteria and why implant fail, how prevent failure of implant, protocol for success implant. And first, clinical success criteria is composed of three factors. First, no peri-implant bone loss, and second, no fracture of implant, and third, no aesthetic problem. First, peri-implant bone loss is occurred in the implant. So after loading, this peri-implant tissue is impacted and peri-implant bone is resolved. And sometimes buccal bone plate is decreased, and implant component, abutment and abutment screw and fixture could be fractured. And third, the gingiva and the buccal bone is decreased, and finally the abutment and implant picture is exposed. As a result, the aesthetic problem is severe. Why implant fails? First, crestal bone loss. We have to understand two factors. First, crestal bone loss for at least 3.8 mm biology width around implant restoration. And second, to avoid losing bone height, the buccal bone thickness should be at least 2 mm. And second, implant fracture. So heavy occlusal loading on implant induces implant fracture. And second, lower mechanical strength of implant could reduce implant fracture. So natural tooth have 700 Newton force, but patient have complete denture. Thus, occlusal force is reduced to 150 Newton. And upper maxilla, upper denture and mandible overdenture on implant have 220 Newton force. So occlusal force is higher in the natural tooth, and female and male is different in the occlusal force. So male have a higher than woman. Men have a 500 Newton force, but female have 340 Newton force. And second, the implant mechanical strength is different. So especially wide implant have a low mechanical stress. So the stress of regular implant is 30% higher than wide implant in low first molar. And third, aesthetic problem. Emergence profile is a major factor in the cervical aesthetic appearance. And second, smile line of incisor edge and gingival line is important in aesthetic appearance. So we have to adjust this incisor and cervical line. How prevent failure of implant? First, crestal bone loss have to be prevented. So 4 mm biological width around implant restoration have to be maintained. So we have to do mucogingival surgery and deep implant placement in bone. At least 2 millimeter buccal bone width around the crestal implant. So we have to do buccal bone graft and lingual implant placement. Implant fracture could be prevented by the masseter Botox injection. So masseter muscle force is decreased. And second, we have to increase mechanical strength of implant. So we have to do use wide implant component, and the restoration have to be splinted. Aesthetic problem could be prevented by emergence profile fabrication and smile designing. Especially this emergence profile is made by anatomical healing abutment or customized provisional restoration. And smile line designing is made by tooth component, radial, and soft tissue line and soft tissue volume. Protocols for successful implant. First, biological width. This protocol is mucogingival surgery and deep implant placement. At first, mucogingival surgery. We have to get biological width. This biological width is composed of junctional epithelium height 2 millimeter, and connective tissue height is 1.3 to 1.8 millimeter. Total 3.5 to 3.8. So at least we have to keep the 3.8 millimeter biological width. So a site where the rich mucus prior to abutment connection was made is seen under 2 millimeter. Wound healing consistently include bone resorption. So here, this after bone graft, the gingival thickness is only 2.1 millimeter, and the spontaneous healing site have a 3.33 millimeter thickness of gingiva. So if you did socket bone graft, so the implant had to be deeply placed about 2 millimeter. So and crestal bone is occurred higher in the thin biotype. So if there was thin, just in thin biotype have under 2 millimeter, implant is placed the same as the crestal bone level, since the marginal bone is resolved. Because to get biological width 3.8. But thick biotype gingiva, there is no any bone loss because already the biological width is maintained. So we have to keep the 4 millimeter gingival thickness implant during implant placement. So here, the 4 millimeter gingival thickness is advantage in the emergence profile. So we can get natural emergence profile. If we establish 4 millimeter gingival thickness. At first, if this gingiva thickness have 4 millimeter, we don't need to make biological width, so we can trepide gingiva, especially in the adventitious maxilla. So we can use surgical guide and trepide. So this system reduces surgical time, and the surgery is changed to simple. And usually we do rotational flap around the implant. But implant thickness have to be of 5 millimeter in width. So between picture and picture, space is filled by rotational flap. And like this, there was thick, wide gingiva in palatal side. So incision in palatal side and rotated and sutured like this. And here, palatal side gingiva is incision and flap is rotated and sutured. In mandibular molar side have atrophic ridge. So there is no attached gingiva. So pre-gingival graft is made in part of maxilla, and graft is divided and grafted on the denuded buccal side on the periosteum and suture. Fourth, dermal matrix graft. So, thin, which have no attached gingiva. So after implant bone graft, dermal matrix is grafted on bone graft and suture. So we can make a thick biotypes gingiva around implant. So there is no bone loss during 2 years. So we have to keep the primary growth of the dermal matrix, and we can increase gingival thickness. So we can replace the autogenous connective tissue graft. Here, dermal matrix graft made thick biotype. And this case, 44, there was no buccal bone graft, and the dermal matrix is covered of graft site. And the 1 year, 10 months, this new thick buccal plate, and there was no bone loss. It's same in the 46 site implant. So there was no buccal and lingual bone graft, and the dermal graft made intact cortical bone, and there was no any bone loss. So deep implant placement could prevent marginal bone loss. So in thin biotype site, implant is placed sub-crestal position. So, we can maintain the 4 millimeter between implant top and gingival crest. One article proved sub-crestal bone level implant placement to show the crestal bone loss was lower than crestal or supracrestal bone level implant placement. So the real with the implant we can measure this the biological with 4 millimeter depth. Implant will have stop. Stop height is about 4 millimeter, and the peak drive have also some line, depth line, and the short and long picture drive have a different this depth index line, so you can check, identify the depth. So you can get biology with a 4 millimeter. So in this, buccal bone, buccal gingiva is resolved, and thickness is 2 millimeter. Implant is placed in the sub-crestal level, and initial top value was over 45 Newton centimeter, and while the 7.5 healing abutment is fixed with 35 Newton centimeter torque for prevent screw loosening, and the flap is fixed with the lateral position flap. After a 1 month healing period, the gingival emergence profile is established, and the implant was made. So we can control the depth of implant placement with implanted rib. And protocols for successive implant second buccal bone withers. How can we make a buccal bone withers? First, lingual implant placement, and second, buccal bone graft. So we can make a lingual implant placement with lingual position drill. And so finally, implant is positioned the lingual side. So distance between the implant and buccal bone surface could be get to at least 2 millimeter. Case Maxilla canine is extracted, and Atraumatic extraction is critical, and implant is placed in lingual side or palatal side, and then provisional restoration is set immediately, and after 2 months, final restoration was inserted. So we can maintain the gingival line with the emergence profile of provisional restoration. And bone graft, if there is no buccal bone, we do GBR technique. So GBR technique is mainly composed of bone graft and the barrier membrane, finally the primary close, and then the second surgery for the healing abutment or emergence profiles restoration. But I want you understand this GBR technique. So today I will introduce the BMP implant buccal bone graft. Characteristic is there is no barrier membrane, and at early stage, new cortical bone and bone marrow is formed, and the higher bone to implant contact percent is different with conventional GBR. So we can do early loading. So we have a lot improvement in this result. Loading period is shortened by the buccal bone graft with BMP implant and healing abutment. In anterior ridge of upper and lower side, the implant is fixed of 40 Newton centimeter. We can connect immediate restoration and loading. In the posterior ridge of mandible, implant was fixed of 40 Newton centimeter. We can connect wide healing of and this after 1 month we can insert restoration, and in the posterior of maxilla, implant was fixed by the 40 Newton centimeter torque. This we can connect wide healing abutment. This posterior restoration is connected after 2 months. So we can short this loading period because it's healing abutment, wide healing abutment or immediate restoration induce more compact and mature, well-organized peri-implant bone. So we can shorten this healing period and loading time. And long-term follow-up check show this buccal bone graft with implant during 6 years. New cortical bone and the biological withers is maintained at 34 site and 35 implant site. So this bone height 10 millimeter and 6 millimeter was maintained in the 34 and 35 site. Mandibular incisors. There was no buccal and lingual bone. So implant placed and healing abutment connected. After 2.5 years, the buccal and lingual bone was formed and maintained. So gingiva line is also maintained. Here, upper incisors, implant is placed immediately, and restoration is inserted at surgical time. After 10 months, after 2 years, 9 months, the buccal bone is maintained, and gingival line is maintained. And buccal defect of mandibular molar. So the buccal bone graft with the implant. So healing hormone connected. After 10 weeks, restoration was inserted. So after 1 year and 6 months, new cortical bone buccal plate is maintained, and gingival line is also maintained. In case there's a buccal defect in maxilla incisors, defect height was about 10 millimeter. So implant was placed with biological withers placement level and bone grafted, and immediate restoration was inserted and healed after 1 month, and changed the final restoration on 3 months. The buccal bone was made and maintained. Low or molar case. There was no buccal bone, implant was placed, and there is no buccal bone. So buccal bone graft with a BMP implant and healing abutment. After 6 weeks, the impression was taken and restoration was inserted. So result, after 10 months, the bone is maintained. About 6 millimeter buccal bone height was increased, and lower anterior 2 millimeter buccal bone is detected around the implant bone graft suture. 10 days after 1 month, final restoration was inserted. The result, after 9 months, the bone, buccal and lingual bone is maintained. And mechanical strength could be increased with a wide implant component and splinted restoration. This wide implant component have higher initial torque value, and so we can reduce loading time, and stress of crestal bone in wide implant is the same as two regular implant. And so the stress of crestal bone in wide implant is lower, 70% than regular implant. So we can reduce implant number with a wider implant. So then we have to use wide implant if the reach width is enough. In this regular size, regular diameter implant have peri-implant bone loss. So we recommend wide implant in the molar of diameter 5 and 6 in the molar side, and premolar and upper canine is recommended diameter 4.5 or 5, and lower canine diameter 4 and 4.5, but lower mandible 3.5 diameter or 4 is recommended because there is no this occlusal force lower and about 10-fold compared to second molar. So, and first maxilla in size is recommended diameter 4 or 4.5. Sometimes I use 5 diameter. So mechanical splinted restoration reduce stress of crestal bone about 75% lower than non-splinted implant. So we can decrease implant number. So breach could be possible and safe. So about 75% is reduced by splint in the premolar. So implant, in this case, implant should be splinted. First, reduce number of natural occlusal stop. So this means there is no number of occlusive lower maxilla tooth. So we have to reduce implant. We have to do this splint restoration. And second, patient have a steep anterior guidance. So in this case, have a heavy lateral force in the anterior tooth. So we have to do splint. And the patient have a tooth grind in sleeping time, or as a parafunctional or heavy. So we have to do splint restoration. And implant position is off axis and angulated, especially the oral pole or zygomatic implant. And sometimes implant is avoided sinus cavity. So implant is placed in diverse orientation. In this case, we have to do splint because there's ocular stress have to be reduced by splint. And the implant is placed about round arch type, not line type. So in the canine involved case, so the implant position is arched. In this case, we have to do splint. 6 is same arched side, and 7 adentral maxilla, especially anterior tooth, the cross arch bridge have to be splinted because this maxilla bone is soft bone quality. So the heavy pole will induce peri-implantitis. So the splint is better. And emergence profile is important in aesthetic appearance, and emergence profile prevent food infection. A is the first wide healing of mouth, and second a centric healing of mouth, and third customized provisional restoration is essential protocol. This emergence wide healing of mouth means diameter 6.5 and 8 healing of mouth. Yes, lateral position flap is wide, divided. So this we can get sufficient wide gingiva in the atrophied region. So this finally, so wide healing amount made wide gingiva thickness and natural emergence profile of restoration. And we can reduce the healing period. But there was no palatal bone in maxilla. The implant diameter was 5 millimeter. So the implant was fixed about 40 Newton centimeter. The palatal side bone graft with implant and the wide healing of mouth. This healing of mouth is a centric healing of mouth. So bone graft side is covered by the centric healing of mouth, mechanical support. So lingual side is longer, long arm healing of mouth, and this bone graft protected by the centric healing of mouth against this tongue press. So we can maintain the bone volume. And finally, after 2 months, crown was inserted. So we could check again at 5 months. The gingiva was intact. This emergence profile was maintained. And here, molar side. Buccal bone was resolved around the implant. So implant, buccal bone was grafted and eccentric healing of mouth. After 1.5 months, a new crown is inserted according to new emergence profile. So emergence profile was maintained, the natural shape gingival line. And lower, if you use customized provisional restoration, we can get the natural gingival line. So I will show some case here. This 11 tooth is extracted. I used the Atraumatic installation kit. Here, crown was fractured. Luxated with the and first drill, 1.7 drill is drilled into canal, and then 1.8 screw is inserted, and luxated, extracted, and implant drill is used. First, point drill is inserted in palatal wall, and direction of drill is perpendicular to palatal wall slide, and then change the to implant direction. So you can check the stop height 4 mm. Here, drilling depth is 4 mm from crestal bone, this crestal margin of gingiva. So we can maintain the biology with us 4 mm during drill. And BMP implant is inserted. Diameter was 4.5, length is 14. And implant top force was over 40 Newton centimeter, and the implant placement level was 4 mm. We can check this depth line of picture drive. And then resin rapid temporary abutment is connected. And I used provisional cylinder, and resin is added cylinder, and crown is removed. Cervical resin filling, and then inserted, trying, customized emergency profile and provisional restoration is made. And then screw hole is filled with resin. This standard X-ray showed the emergency profile is maintained during 2 months, and impressive. This emergency profile sub-gingival ceramic margin and angled screw channel is used, and final restoration. If you keep the drill depth and the buccal bone width 2 mm, So there will be no marginal bone loss and peri-implantitis. So rest case. Eleven side and here. There is no buccal bone at 11 side. So this bone quality is 2 or 3. So we can do immediate loading. So 11 side we have to do buccal bone graft. First implant reel. So lingual wall is penetrated with pointed drill in 2 sides. And 2.2 drill, you have to check the drill depth in the stopper. We can maintain 4 mm depth from gingival crest. Here, just stop, maintain, coincide with the gingival crest. And diameter 4. Finally, diameter 5. You can check stopper 4 mm level, and then incision and grain tissue is removed with blade. The buccal side have granulation tissue in the defect side, and the blade cut the gingiva and grain tissue connection, and then cut it the grain tissue. The buccal defect depth was about 8 mm from gingival crest. And graft first, alloderm. The dermal matrix is inserted on the buccal gingiva, and then bone graft inocap is put in buccal side. Finally, implant is placed. You can check the implant placement depth 4 mm. Provisional bridge. I use diameter 5 mm implant, so the 2 implant and bridge is safe. And temporary bridge itself is attached on the impression coping by the light curing resin, and the gingival line is peeled and removed. In chair side, this emergence profile is made, and the screw hole is maintained, and polishing and trying. Occlusal check. result of surgery. The buccal bone graft is good. After 2 weeks, this gingival line is maintained and restoration is removed. Emergence profile is made during 2 weeks, and impression cooking is inserted. By the impression cooking is impressive. By the impression, and by the impression copying is connected into replica, and this assembly is inserted into impression. And a speed zirconia bridge is connected on 3 weeks after surgery. Emergence profile is maintained. And here, the aesthetic and the emergence profile and smile line is fabricated. So we have to do record check for the evaluate gingival and the peri-implant tissue health and maintain the plaque control and calculus control, and we have to check this screw loosening of abutment and restoration, and so sometimes we have to do periodontal treatment. So this record check have to be maintained at least 5 years. And we have to check it some smoking status and plaque index, modify the circular breathing index for the evaluate gingival health, and X-ray. So if patient have some problem in the oral hygiene ability or some systemic disease, periodontal disease, so we have to check the patient frequently. So your patient have to be managed by your intensive record check. Thank you.